And what's your take in the management on second line? How do you strategize your patients there?
Right. So we now have quite a few options at our disposal here, and with regorafenib being an option in people who have tolerated sorafenib at least the 400 milligram dose. Cabozantinib recently approved just last week in both second line and third line, so that being a distinction compared to rego. And also pembrolizumab and nivolumab are both approved in the U.S. now with accelerated approvals based on single-arm phase 2 data largely. So I do have to say I have a tendency to use an immunotherapy drug in the second line in certain cases, particularly patients who did not respond well to a first-line TKI, either lenvatinib or sorafenib. In part because of while we don't have randomized phase 3 data to guide this decision yet, I think right now the fact that there are potential robust and durable responses that we have seen consistently across trials, whether it's the camrelizumab trial or the pembrolizumab trial or the nivolumab trial, we know that there's the 17% roughly response rate across those studies. I think in patients who did not respond well to a tyrosine kinase inhibitor, I prefer to try an immune response, an immunotherapy agent, in hopes that they are somebody who derives benefit before they decompensate and are unable to receive any therapy. Now, in someone who had a prolonged benefit on first-line tyrosine kinase inhibitor, such as regorafenib, or such as lenvatinib or sorafenib, I do tend to use a TKI next if there was mild progression and prolonged benefit, similar to the data we see from the resource trial, which shows us such nice survival benefits in those patients who had response to sorafenib followed by regorafenib. And similarly, I think the data are coming that cabozantinib in sequence also achieves prolonged benefit. So that's generally my strategy in the second line.
Very good. And so there is also the question on those patients with very aggressive tumors, right? So you have a patient that has been on, let's say, sorafenib or lenvatinib in front line, but also already has the progression at 4 months and has aggressive tumor, AFP of thousands, and extrahepatic disease, and so on and so forth. With these aggressive tumors, now we also have ramucirumab for those, but looking at the subgroup analysis, certainly regorafenib works well for these patients, cabozantinib works well. And as you have said, if the patient is lucky enough to have a immune hot tumor responsive to nivo or pembro, it will be also a plus. So in these very aggressive tumors, how do you manage to decide which is the best option?
I think this is where this is going to define the next decade of research. We spend a lot of time after sorafenib trying to find the next treatment options, and I think we have our work cut out for us with the current trials to really look into the biospecimens and correlative analyses to try to understand what are the non-invasive markers that can help us identify those immune responsive tumors or the immune subclass that you've just defined really, and how to define that in a clinical setting rather. But in the short term, without that answer at hand, I do try to use immune therapy in the second or third line at least, and then sequence the TKIs to the best of our ability. But if with the advent of ramucirumab as well, that adds an extra tool for the high AFP population.
Second-line agent that we have currently, the regorafenib is approved, and cabozantinib, ramucirumab will be approved. Not yet approved. In United States last week, cabozantinib was approved, and in United States, nivolumab and pembrolizumab also were approved. So in the U.S., you have many choice, and after sorafenib or after lenvatinib, you have 4 second-line agents and 2 checkpoint inhibitors. But in Japan, currently only regorafenib. But soon, ramucirumab or other agent will be approved.